Okay, so imagine you're working somewhere connected to Medicaid funding, maybe a healthcare provider. What are your actual responsibilities for billing, for compliance? And what happens if you feel like something's not quite right?
Yeah, that's a really important question.
Today, we're going to dig into a pretty critical document. It's called Policy A500. It basically lays out the whole Medicaid compliance program for the New York State Office of Mental Health, OMH.
And this isn't just some dry policy document, right? I mean, it sounds like it could be, but it's really about ensuring taxpayer money is used properly.
Exactly. And that ethical practices are followed, which, directly impacts the quality of care people receive.
So this deep dive, the idea is to give you a clear picture of the expectations, the definitions you need to know, and how reporting works within this OMH system for Medicaid compliance.
Right. So whether you're maybe in healthcare admin or just curious about government oversight or, want to be an informed citizen.
This should give you some valuable insights. It's complex, definitely, but it's vital stuff. We'll try to break down the key parts without getting lost in all the jargon.
And our main source here is Policy A500 itself. These excerpts outlining the rules for preventing fraud, waste, and abuse in Medicaid, specifically within the OMH context.
That's the plan.
Okay, so let's kick things off. Who exactly needs to follow this policy? It sounds like it casts a pretty wide net.
It really does. The policy uses this term, affected individuals, and that covers, well, a lot of people. Obviously, OMH employees themselves,
Uh-huh.
but also contractors who provide services, clinicians, other professionals working with OMH facilities, even paid student interns if they're working in the system.
Okay, interns too.
Basically, if OMH has direct control over your work for the office, this policy applies.
So pretty much anyone contributing to OMH's work is potentially covered. But I remember reading it goes even further than just direct OMH folks, right?
Yeah. Yes, exactly. That's a key point. The definition of affected individuals is specifically expanded. It includes the provider's employees, too.
Ah,
Their senior administrators, their managers, any contractors they might use, agents, subcontractors, independent contractors, even the provider's governing body and corporate officers.
wow. So it's not just OMH, it's the whole network involved in delivering those Medicaid-funded services through OMH.
That's right. It highlights just how comprehensive they intend this to be. System-wide accountability, really, which, makes sense, but also creates challenges for training and communication, making sure everyone from an intern to a CEO understands their part.
Definitely a broad scope. Okay, so the policy uses specific terms: abuse, fraud, waste. These might mean something slightly different here than, an everyday chat. Can we break those down?
Absolutely. Let's start with abuse. And Policy A500, abuse means provider practices that are, let's say, inconsistent with sound fiscal, business, or medical practices.
Inconsistent how?
Well, the key thing is the result. These practices lead to unnecessary costs for Medicaid, or maybe they get reimbursed for services that weren't actually medically necessary or didn't meet professional standards.
Okay, so it's about the outcome being wrong,
Yeah.
leading to extra cost or improper service reimbursement, not necessarily intentional bad action.
Exactly. The intent isn't the defining factor for abuse, unlike fraud. It's more about irresponsible practices or not following best practices.
Got it. So that brings us to fraud. That sounds like it does involve intent.
It does. Fraud is defined as an intentional deception or misrepresentation. And it's done knowing that this deception could result in some unauthorized benefit, either for themselves or someone else.
Deliberately misleading the system for gain.
Right. And the policy even points to specific acts prohibited under Social Services Law, Section 3666B, grounding it legally.
Okay, that's clear. Abuse is bad practice with bad results. Fraud is intentional deception. What about waste?
Waste is simpler in a way. It's about overutilization, underutilization, or just misuse of resources. Basically, not using resources wisely or efficiently.
So like ordering excessive tests or, conversely, not providing necessary services efficiently.
Could be either, yeah. It's
Ah,
about inefficiency and inappropriate use of what's available.
okay, abuse, fraud, waste.
Got it. The policy also defines the compliance program itself. What's the official take on that?
The compliance program is described as a proactive and reactive system. It includes internal controls, procedures, policies, the whole structure a provider sets up.
And the goal?
The goal is to make sure they consistently follow all the applicable rules and regulations. It's the framework policy A500 supports.
And overseeing this framework is the compliance officer.
Correct. That's the designated OMH Medicaid compliance officer. They're central to making it all work. And you'll also see OMIG mentioned.
Right, OMEG.
That's the NYS Office of the Medicaid Inspector General, an external body providing that independent oversight piece for the whole state Medicaid program. Important distinction. Okay, two more terms jumped out. Intimidation and retaliation. Crucial for reporting, I imagine.
Absolutely critical. Intimidation is basically any coercion or threat aimed at stopping someone from reporting suspected fraud.
Like pressure from a boss.
Could be. And retaliation is even more specific. It's any adverse employment action taken because someone reported suspected fraud.
Like getting fired or demoted.
Exactly. Or even things like being disciplined unfairly, denied a promotion, moved to a bad assignment, refused time off, or even just being shunned by coworkers. The policy lists these examples.
Wow, they really spell it out. Good. You need people to feel safe reporting.
Precisely. Without that protection, the whole reporting system falls apart.
Okay, so we know who's covered and what the key terms mean. What does Policy A500 actually expect from all these affected individuals? It seems like more than just don't commit fraud.
Oh, definitely. It sets out core expectations. First, everyone involved has to exercise diligence, care, and integrity when they submit Medicaid claims.
Diligence, care, integrity. So being careful and honest.
And specifically, honest, fair, and accurate billing is mandatory, not just encouraged.
Makes sense. That's foundational. What else?
Timely reporting of suspected fraud, waste, or abuse is required. You don't have to be 100% sure. Suspicion is enough to trigger the reporting duty.
Okay, report suspicions promptly.
Also, compliance with all relevant state and federal laws, rules, and regulations for Medicaid, that's a big one.
Yeah, that covers a lot.
And it includes following current OMH policies, procedures, accounting rules, procurement rules, internal controls. It's a whole ecosystem of rules.
So stay informed and follow everything. Sounds demanding.
It is. The policy also explicitly prohibits filing false, fictitious, or fraudulent statements or documents related to healthcare benefits. Kind of overlaps with fraud, but stated directly.
Right. No funny business with paperwork.
An accurate, honest, timely documentation of all services and transactions is required. Documentation is key.
Always. What about enabling bad behavior?
Good point. Individuals must refrain from participating in, encouraging, directing, facilitating, or even just permitting non-compliant behavior. You can't just look the other way.
So there's an active responsibility not just to comply yourself, but to not allow non-compliance around you.
That's the expectation. It fosters a culture of compliance.
So if an employee does know about a violation, what's the specific procedure?
The policy is clear. If you know about a violation of law or policy that could reasonably be seen as fraud, corruption, misconduct, you have to report it promptly. You can go to your direct supervisor, or you can go straight to the compliance officer. And importantly, supervisors who are told about something or suspect something themselves also have a duty to report it up the chain or to the compliance officer.
So the buck keeps moving upwards until it hits the compliance officer, essentially.
Or gets addressed appropriately along the way, yes. The responsibility chain is defined.
And that fear of getting in trouble for reporting the policy addresses that head on.
Absolutely, and very directly, OMH and its employees are prohibited from intimidating, threatening, coercing, discriminating, or retaliating in any way against an employee who reports in good faith.
Good faith being the key phrase there.
Yes. Or someone who participates in an investigation or even just opposes a practice they reasonably believe is unlawful or violates the program. It's strong protection.
That's reassuring. But what if someone doesn't comply? We talked about expectations, but what are the teeth? What happens?
Failure to comply can lead to administrative action.
Yeah.
The policy says the severity depends on the violation.
So it's a spectrum.
Right. It could range from needing retraining or getting a formal reprimand all the way up to financial penalties, suspension without pay, or even termination.
Okay, serious consequences.
For OMH employees, the process follows existing rules like Civil Service Law, Section 75, and union contracts. For contract staff or people working for vendors, OMH might refer it back to their employer for action, or OMH could just terminate the business relationship.
So it impacts contractors too, potentially losing the contract.
Definitely. It ensures accountability across the board.
All right, so we have these expectations and consequences. Let's talk about the people and groups making sure this system works. The compliance officer, we mentioned them. What's their specific job description look like under this policy?
The OMH Medicaid Compliance Officer has a really significant role. Their main job is monitoring the whole OMH Medicaid compliance program and importantly, doing it with independent oversight.
Independent even within OMH.
Well, they report directly to the Executive Deputy Commissioner and the OMH Compliance Committee at least quarterly. So high-level reporting, keeping leadership informed.
Okay. And day to day, what are they doing?
A lot. They draft, implement, and update the compliance work plan that has to be reviewed at least annually. They review and revise the main compliance program policy itself, policy A500, and related policies to keep them current.
Keeping things up to date with laws and regs.
Exactly. They prepare those quarterly reports. They communicate requirements to management and staff. They ensure training materials are current and accurate.
The training piece, right.
They investigate allegations of fraud, waste, abuse. They handle submitting self-disclosure reports to OMIG if OMH finds an issue itself. And they make sure annual compliance certifications get submitted.
Sounds like the central hub for all things compliance.
It really is. And crucially, the policy states OMH must give the compliance officer sufficient staff and resources.
Resources like budget and people.
Yes, and also access. Unrestricted access to all necessary records, documents, information, facilities, and importantly, all affected individuals. They need that access to do their job effectively.
Makes sense. You can't oversee what you can't see. Now, you also mentioned a compliance committee. What's their role? Are they managing the officer?
Not directly managing day-to-day, but they assist agency management in overseeing the program. Think of them as providing higher-level guidance and ensuring ethical and responsible business practices across the agency in line with the program.
Okay, an oversight and advisory role. Who's on this committee?
They're appointed by the OMH Commissioner. It has to include the Executive Deputy Commissioner and senior managers from key areas, finance, operations, legal, etc. Minimum of 7 members.
A cross-section of leadership. And what do they actually do?
They coordinate closely with the compliance officer on developing and implementing the program. They ensure OMH has good systems for identifying risks and overpayments and clear policies for correcting and reporting them.
So making sure the infrastructure is solid.
Right. They promote communication about compliance issues across OMH. They review policies and training to make sure they're complete and effective. They advocate for the compliance officer to get the resources they need.
Ah, so they support the officer's role too.
Yes. And importantly, they conduct a full review of the entire compliance program annually to see how well it's working and where it needs improvement. And they report directly to the commissioner.
So compliance officer runs it, committee oversees and supports, reports to the top. Seems like a solid structure.
It's designed to be, with checks and balances.
Wait, let's shift to training. You mentioned the officer ensures materials are up to date. How central is training in policy A500?
Very central. OMH mandates that all affected individuals get trained on the compliance program.
Everyone we talked about earlier, employees, contractors, interns.
Everyone. The training has to cover things like how to spot issues, what the policy expects, how the program works. And a big piece is emphasizing OMH's commitment to following all the federal and state laws for Medicaid.
Including those whistleblower protections.
Yes, specifically includes info on the False Claims Act and whistleblower protections as required by the Federal Deficit Reduction Act.
When does this training happen? Just when you start.
New hires get it within 30 days. There's a specific Medicaid compliance new employee training brochure they use, often delivered through the state's online system, SLMS.
SLMS, right. What if someone doesn't use a computer regularly?
Then, the facility where they work is responsible for providing the training directly. And the brochure is available to everyone on the OMH internal website, the Hub.
Okay, initial training within 30 days? Is that it?
No, there's mandatory annual compliance training for all affected individuals, too. Again, employees and contractors.
Every year.
Every year. Delivered the same way, typically SLMS or through facility training offices, and they take record-keeping seriously. Records of who took the training have to be kept for 15 years.
15 years, wow. That really shows they mean business about tracking this.
It underscores the long-term importance they place on it.
Okay, so people are trained, they know the expectations. If someone does suspect an issue, what are their options for reporting? You mentioned the compliance officer, but are there other ways? It seems important to have multiple avenues.
Absolutely, and OMH provides quite a few. They want to make it as easy and safe as possible. There are confidential and even anonymous methods.
Like what?
There's a public-facing online submission form on their website that offers anonymity.
Okay, online form.
You can talk to your direct supervisor, who then has a duty to act on it or escalate it.
Supervisor, got it.
There's a direct phone number for the compliance officer, 518-549-5378, and a specific email address, compliance at omh.na.gov. Only the officer and their staff access that.
Direct contact, phone and email.
You can use regular U.S. mail to send something to the compliance officer in Albany.
Snail mail, okay.
There's also the OMH Customer Relations line, which is interesting because it has interpreter services available.
Oh, that's good for accessibility. 1-800-597-8481.
Right. And they also explicitly list ways to report externally, directly to OMIG, the state Medicaid Inspector General. They have a hotline, 1-877-878-40G, and a website.
So you can bypass OMH entirely if you want.
Yes, or report to the state Inspector General's office, 1-800-DO-RIGHT, or their control unit, 212-417-5397. They really provide a wide range of options.
It certainly seems like they want people to report somewhere, and confidentiality is protected.
The policy states confidentiality will be maintained to the fullest extent possible. Exceptions would be if disclosure is required for disciplinary proceedings, law enforcement investigations, or legal actions.
The default is confidentiality.
Yes. And crucially, reporters are protected from intimidation and retaliation, as we discussed.
Right. So going back to consequences, we talked about discipline for violating the policy. What about not reporting? Is there a consequence for just staying silent if you see something?
Yes, absolutely. Policy A500 explicitly says all affected individuals have a duty to report suspected issues. Failing to report is itself considered non-compliance and can lead to disciplinary action.
So silence isn't a safe option either.
No, the expectation is active participation in maintaining compliance, which includes reporting.
And just to hammer it home, reporting in good faith is protected. Retaliation is forbidden.
Unequivocally, no adverse personnel action for good faith reporting. But the policy does note that reporting in bad faith, like maliciously or for personal gain, could lead to discipline. It protects genuine whistleblowers.
Fair enough. Okay, OMH is huge. Lots of facilities, programs, people. How do they proactively try to find compliance risks before someone reports them? They can't just wait for the phone to ring, right?
No, you're right. Proactive identification is key. They have several routine processes. For billing risk, for example, they do regular reviews of their billing systems.
Checking the software and process.
Yeah, validating system edits things designed to catch errors automatically, like checking against EMN-NY edits or client restriction codes. They do desk reviews of patient resource agent cases to make sure billing is going to the right insurer.
Looking for patterns or errors.
Exactly. Monitoring electronic medical records to ensure data needed for billing patient movements, diagnoses is accurate. Generating reports to flag services that should be billable based on patient status and provider license, and client management monitoring to catch potential duplicate bills.
So lots of data analysis and checks on the billing side. What about payments? Risks related to money going out or coming in?
They have controls there too. For Medicaid reimbursements coming in, they use monthly negative receivable reports and quarterly reconciliations. For outgoing salary payments, they use automated time and attendance systems like LAT-SITARs that need supervisor review and approval.
Checks and balances on payroll.
Right. And for paying vendors, they verify contracts are current, valid, specify services, payment terms, amounts. They review invoices against those contracts and ensure everything follows state ethics and procurement laws.
Okay, controls on money flow. What about the actual services ordered for patients, lab tests, therapy, things like that?
For ordered services, the focus is on cost effectiveness and medical necessity. They need to consider less costly alternatives if clinically appropriate, and clinicians need to document why a service is medically necessary in the patient record. Licensed clinicians only, of course.
Documenting the justification. Makes sense. And what about the big picture quality of care? How does compliance touch on that?
Medical necessity and quality of care are definitely part of the compliance picture. OMH has programmatic quality reviews like surveys. They use the NEMR system, New York Incident Management and Reporting System, for real-time oversight of incidents and abuse allegations.
MMRs.
They maintain a policy manual specifically on quality of care, and they conduct admission and continued stay reviews to constantly assess if the level of care is medically necessary.
So it connects directly to patient care standards. Good. What about just the structure of OMH itself? Does governance play a role?
Yes, governance is listed as a risk area they monitor. The policy mentions OMH's organizational structure commissioner, executive deputy commissioner, leadership teams, facility governance teams. Having clear roles and responsibilities helps ensure accountability.
And if they do find improper payments themselves, how is that handled? Is there a process for reporting that up?
Yes, mandatory reporting processes. They have systems to identify and report improper payments to CMS, Centers for Medicare and Medicaid Services, and state control agencies. This includes annual independent audits of things like Medicaid disproportionate share payments and regular financial reporting to the state comptroller and division of budget. Transparency is built in.
Okay. Two more risk areas mentioned are credentialing and contractor oversight. How do they manage those?
Credentialing is about making sure staff are qualified. They have policies to verify employee qualifications and ensure licenses and credentials stay current. Standard HR stuff, but critical for compliance.
Verifying licenses, right? And contractors.
For contractors, subcontractors, agents, they provide them with the compliance program policy and require annual training. They also have to do monthly checks against exclusion lists, databases of individuals or companies barred from federal programs like the OMIC list, the federal HHS OIG list, and SAM.gov.
Monthly checks on contractors against exclusion lists, that seems diligent.
Yes, and annual checks of the National Plan and Provider Enumeration System, NPPS, for individuals and owners. They also screen new OMH employees against exclusion lists before hiring. And existing employees and vendors are screened regularly, too. Some vendors even have to attest they're doing their own screening. Results go to the compliance officer monthly.
Wow, okay. That screening process sounds quite robust for making sure they're not working with excluded parties. So a lot of proactive systems.
Yeah.
But when an issue is reported or detected, what's the response system?
They have procedures for prompt review and investigation of all complaints and allegations. This is all under the compliance officer's direction.
Everything goes through the compliance officer.
They oversee it, reports get logged, even anonymous ones. Then they're referred appropriately. Quality of care issues might go to the Division of Quality Management. Issues with licensed providers might go to the Bureau of Inspection and Certification, or OMIG.
Okay, triaging the reports.
The compliance officer investigates reports of fraud, waste, and abuse within OMH facilities directly, collaborating with other staff as needed. If it looks criminal, it goes to the Bureau of Internal Affairs.
And those finance folks who monitor billing, they have a role too.
Yes, staff in the State Operations Finance Group, SOFJ, monitor billing and claiming. If they spot suspected waste, fraud, abuse, or systemic errors, they must report it to the compliance officer within 5 business days.
5 days, that's quick.
It emphasizes promptness. Now, for more routine incorrect payments, maybe simple errors.
Yeah.
Patient resource agents usually handle those. They implement corrective actions, process refunds. There's that 60-day rule from federal law to report and return identified overpayments.
The 60-day clock.
Right. But if those patient resource agents suspect something more serious, waste, fraud, abuse, it gets escalated to billing operations, involves the SOFG director, and definitely a compliance officer to decide if a self-disclosure to OMIG is needed.
So a pathway for escalation even from routine errors.
Exactly. The commitment is to correct all issues promptly and thoroughly.
Okay. And just to wrap back around to the protection aspect one last time, the non-intimidation, non-retaliation piece. How is that commitment framed?
It's framed very strongly. OMH prohibits intimidation or retaliation against anyone participating in the compliance program in good faith. Reporting issues, assisting investigations, participating in audits or self-evaluations, all protected.
And if someone feels they have been retaliated against?
They should report it to their supervisor or the compliance officer. The compliance officer is responsible for investigating those specific allegations of retaliation.
So there's a process for investigating the retaliation itself.
Yes. And again, while good faith reporting is protected, the policy reserves the right to discipline someone who reports in bad faith or misuses the system. And information on the specific laws, federal and state false claims acts, whistleblower protections is made available to employees on the OMH hub and in HR offices.
Transparency about rights and protections. Okay.
That's the core of it.
So wrapping this all up, what does this really mean for you, the listener? This deep dive into OMH's policy A500, well, it shows a really detailed plan to protect the Medicaid program.
Yeah, it emphasizes everyone's responsibility, sets up strong oversight with the compliance officer and committee, gives lots of ways to report concerns, and promises protection against retaliation.
And that detailed focus on all those risk areas, billing, payments, credentialing, quality, everything. It really shows a serious commitment to trying to prevent fraud, waste, and abuse.
Definitely. But, think about how complex it must be to actually implement and maintain something like this in a huge organization like OMH. What are the real-world challenges day to day?
That's a good point. Policies are one thing. Making them work consistently everywhere is another.
And maybe think about how anyone, regardless of their job title, can actually help build a more ethical healthcare system. This policy is a strong foundation for sure, but making it effective really comes down to the vigilance and integrity of every single person involved.
That's a great final thought.
Yeah.
If you found this breakdown helpful, maybe think about looking into compliance programs in other areas you're interested in. Understanding these frameworks is really key for accountability everywhere.
What questions did this raise for you?
Yeah, dig deeper into the resources if you're interested, and keep thinking about the vital role compliance plays.